We're midway through an NEJM discussion group on smoking cessation. The trigger for it was the publication in the journal last week of a research paper examining a novel approach, that is, paying smokers to stop. We're fortunate to have one of the study's authors, Benjamin French of the University of Pennsylvania. Also, we have Tejal Naik, a medical student at Thomas Jefferson University, who will be moderating the continuing discussion here at MedStro. Welcome. Let me start with an unfair question. Is either of you a smoker?
No.
Okay.
No.
And it's not a totally unfair question, because the USPSTF has said that we should be asking or clinicians should be asking all adults, do you smoke or not? Of course, clinicians can probably detect it with the first two breaths of the patient coming into the office. But and another question: has either of you had to quit smoking before, or tried to quit smoking before? No.
No.
Okay. All right. Well, I have, and I have, and it wasn't easy. And so I recognize the gravity of this research, and I guess the federal statistics say that there are about something under 20% of U.S. adults are smokers at this point. Is that right?
I think that's pretty close.
Yeah, and it got up as close to 40–45% at one point back in the 50s, I guess. Everyone was walking around trying to be Humphrey Bogart or something.
Right.
But that's changed. But still, there's that 20% that are still suffering from the effects of smoking. So let's get to the research that you did, Ben. The elevator summary of your work. So you've got a couple of thousand people that you split into 5 groups.
Yes.
Okay, so one of the groups of the 5 is usual care, which includes, encouragement to stop, access to nicotine replacements, perhaps, and other things. That's
correct, and in fact, everyone in the study was offered those materials.
Right, and then now there are 4 groups left to split up among. You have teams of 6, so the group teams trying to encourage each other to stop smoking.
Yep. And
their reward, if they stop, is they can get up to $800.
Right. The group interventions are interesting because they played on both people's sense of working together in one group, and then in the other group sort of working against one another, where the amount of money you would be rewarded at the end if you won was different based on whether the other people in your group quit or not.
But you could, in no event, earn more than $800 in a group, could you?
I would have to go back and look at those.
I mean, so there was nobody, there was no incentive to be dishonest about it, but you could earn up to $800.
That's right.
And so some of those groups of 6, though, so another group, rather, another of the final 4 was, okay, so the groups of 6 people, and each of the people in the group makes out a check for $150 at the beginning of the test, and after 6 months, if they've stopped smoking and they can prove it biochemically, they get the money back.
That's right.
If not, you get the money or somebody.
Right.
Right. All right. So that's the teams, and now 2 more groups. One, individuals comprised of individuals, and then another. Individuals who could earn up to $800 for stopping smoking at 6 months, and another group who, like the teams, were individuals, but they had to make out checks for $150, and which they would lose if they didn't stop smoking. And if they did stop smoking, they would get that money back plus $650.
That's
So,
exactly right.
so nobody's walking away with more than $800.
Right.
Okay. All right. So so let's shorten this story just for the sense, just for the purpose of our discussion. In general, the usual care group was not as successful as the intervention groups, the groups who stood to make money.
That's right. At the usual care group at about 6 months, around 6 or 7% of them had biochemically confirmed sustained abstinence from smoking.
Right, and the usual care was no, I'm sorry. So that was 6%, and the intervention group were somewhere. If you could pick a number, I would say around 12%.
Yeah, on average, that's pretty close. Yep.
Yes, a success rate.
Yep.
So in the interest of simplifying the story even more, the team approach, the groups of six, the teams of six, were not substantially better than the individuals and their ability to quit smoking.
That's right.
So, but there were some anomalies. So Tejal, I'm sorry, I've been ignoring you, but only apparently. So, hey, did you read the paper, Tejal?
Yep.
You did. Okay. So that. What was there were a couple of anomalies here. One of which was the acceptance rate. So it was a randomized study, right? So you try to randomize me. Tejal tries to randomize Joe into a study, and if I don't like the group, I say no, I don't accept the randomization. That's right, right?
That's right, and that sort of runs counter to anything you'd expect in a randomized trial, right? You're supposed to be in the arm that you randomized into,
right.
But in this case, you might not be.
All right, so Tejal, here we are. You've tried to randomize me into the Joe. I want you to make me out a check for $150, so you can enter the study. And I go, Tejal, I don't think so. I want you. No, I don't want to do that. I don't have the money, and so most, in only 13% of those randomizations where you try to get me to make out a check, do I agree, right?
That's right.
and so you started with 2,500 people, but a lot of people didn't accept randomization, so you had to get them into other groups. Isn't that right?
Well, so if an individual was randomized into one of the deposit groups, or in fact any of the 4 intervention arms, and chose not to accept that intervention, then we continued to follow them and collect their outcome data on smoking abstinence. But which group they were analyzed in varied between our analyses.
Okay.
Yep.
All right. So, Tejal, they've let you onto the floors to see patients. You're in your third year now, right?
Yep.
So what are some of the things that you've seen about? Do you see people coming in, trying to quit smoking or needing to quit smoking, and what are the kinds of interactions you observe with people in that situation?
So I've seen a lot of patients in terms of in the hospital and outside, so like primary care setting, like at like a family medicine clinic, and coming into the hospital. And you always kind of ask the question, do you smoke? And then they would always say, yeah, I smoke. And you'd always ask, would you like some treatment? We have some plans. We have staff. We have other programs I'd be like willing to give to you if you wanted to help to stop smoking. And you have a handful of people who say, I would say most of them would say yes, they want something. but usually they're coming in because of something else than they're smoking. So you kind of focus on that. But I think that's something that we've always been taught to keep following up and keep asking and keep saying, kind of gauge where they are. Some people will only get help if they want to get help. And some people will really say, hey, I want something now. They've been doing it a lot. Like, say, I've been in like a cancer center where people come in with lung cancer, and they get lung cancer because of smoking, for the most part. And then they're just saying, yeah, I want to quit. What are the best choices of quitting? Or I've tried this, it hasn't worked. What should I do next? So I think it's out there. I think one thing like this paper did a really good job in kind of doing is showing like what's alternate ways of bringing like a different kind of face to stopping smoking. So like a different program. So I think that's like a pretty interesting thing. Kind of seeing where patients are, like why would you stop? Other areas like that. Those are also questions that we ask in the clinic.
There was a study. I don't know whether I read it in the course of reading this study or reading something else. It said that if you're a company and you hire somebody who smokes, your added cost for that employee is something like $4,500 a year. Is either of you familiar with that statistic?
No.
Okay.
I'm not familiar with the study, but I've seen like actually in our universities settings, especially actually in the Philadelphia area, a lot of places are becoming smoke-free zones. So employees that smoke aren't likely, I don't remember the exact rules, but they're not likely to get a job or even smoke around, like on campus or around the hospital area.
Yeah, and it must. You see people in sort of social exile outside of buildings, outside of restaurants, around the corner, trying to smoke, and it must be difficult for them. There's one of the anomalies, Ben, in the study was the people who accepted the randomization to the group that had to write the check. Okay,
Yep.
who accepted randomization at first pass and said, okay, I'll accept randomization to that. I'll write out the check. They did much better than anybody else, didn't they, in quitting?
That's right. So your next logical question is then, how did those people differ from those who didn't accept that intervention? Because you would think that the people who might be more willing to quit would be more willing to accept that intervention. And so that's why we conducted an analysis where we attempted to form a contrast between the interventions among those who had accepted either the reward or the incentive program. And that was the instrumental variable analysis that we implemented.
Right, and that's where the language of statistics kicks in, and it's good that people like you have PhDs in it. But for people like me, it's very difficult to follow. But I kept telling myself, yeah, I think I get what they mean here.
Yeah, the goal is just to form a contrast between two interventions among those who would accept either of them. And so you're trying to overcome the selection bias from one group accepting an intervention more often than another.
And so really this study is a study in psychology, probably more in psychology and behavioral economics than in clinical medicine.
Yeah, I might agree with that, yeah.
And people were given access to nicotine replacements, even no matter what group they were in.
That's right.
So it seems like for the people that Tejal sees, that you give them nicotine replacement, but then if you were to say to them, okay, well, there's a reward program here, and you could earn up to $800, and I know that the research that you conducted in the discussion, you talk about, well, we're not sure, how much of a check people should write if they're asked to, get some skin in the game. or
Right.
how much people should be rewarded. And I was doing a sort of back of the envelope analysis, and you know, if cigarettes cost roughly $10 a pack, then you're spending over $3,500 if you're a one pack a day smoker. You're spending over $3,500 a year on cigarettes, which you know, it seems to be a lot of money, but over the course of a year, probably it may not. So I mean, you could raise that reward considerably if you knew that you were going to get a good success rate.
Right, and you know, I don't know a ton about behavioral theory, but I think there's some sense that people don't do very well focusing on events that happen far into the future.
Yeah.
So if you can tell someone, I'm going to give you this amount of money if you quit, you know, that might mean more to them than the savings of not smoking over some long period of time.
Tejal, in the clinics, what other things do you see besides smoking? You know, do you see people who just, you know, weight loss or other personal habits that they're trying to break that you think this might be useful in?
I mean, like, I think, like, what ended up happening with what you guys were just talking about is a great transition, because a lot of people, like, especially smokers, or you see, like, in other areas, like, people who have come in with high blood pressure, diabetes, type 2, high cholesterol levels. These are people that, like, they have medication to take that do a pretty good job in reducing, like, their blood pressure and all that. The problem is that they don't understand the long-term benefits. So they want something that, you know, brings the level down, and they say they feel fine right now, and they see, like, you know, the problems will be like the side effects from the drugs. But in the long term, when they get the heart attack or they get some other issue, they're like, oh, I shouldn't have done that. That's something I saw with the smoking, was you'd see people who had been smoking for 20 years, quit for 20 years, or something, and then they'd come back and get lung cancer and be like, oh, that was me when I was younger, didn't know any better, and now it's like, oh, it really hit me, I should have stopped then. I think that's the same thing we see, like you were saying, in weight loss and other areas, is that I've been in, like, many clinics where weight loss management was something, and patients don't see the issues now because they see the immediate benefit of, hey, I got some whatever my favorite food is, it made me satisfied, going through maybe some other things that's going on, stressors in life, and that made me feel better at that moment instead of learning about, like, long-term benefits.
Yeah. Well, Ben, what I know that you're the statistician in the group, and you're not a clinician, so you don't see patients. But from what you hear, and the behavioral aspects of this research, are they pointing to other research projects that you can talk a little bit about, or not?
Yeah, the group that I work with has done other work in terms of weight loss, in medication adherence, in terms the weight loss one are interesting because some of them are some of the studies are to look at incentives for actual weight loss, and some of them are just to get people to check their weight and to be monitoring it. And then, like I said, I've worked on others that are to increase adherence to maintenance medications like warfarin and others. I think they may be doing some in diabetes, but I'm not sure. Yep.
Yeah, but so those are underway. So this is a kind of it attacked a big problem, smoking, but there seemed to me, as I was reading the research, implications in other areas as well.
That's right.
Yeah. So Tejal, I understand that you're an entrepreneur as well as a medical student, and I've been meeting a lot of young entrepreneurs who are in residencies and things like that. Any of this research relate to your entrepreneurial drives?
Yeah, actually, because I've actually had a lot of, like, I never smoked, but I have a lot of family members who smoke. I've got them to quit. It was like a long, grueling process,
Yeah.
but something that can make it easier, especially not just from my side, or like, say, someone in a family situation or friends, but like for the individual themselves. There's been like apps out there, kind of talking before, like weight loss management, kind of like the Fitbit revolution that's been going on.
Yeah.
There's also kind of like, is there an app that kind of goes from like behavioral characteristics or targets vital behaviors that say like you can design an app where when we have location like GPS on our phones. So say if they go to their local Wawa or the local some kind of the gas station, where anywhere they get like their normal round of cigarettes, you can have a beep on your phone that says, "Hey, don't buy this," or "Hey,"
Right.
something like that, some kind of alert, and maybe kind of reinforcement over time can stop them. So that's something like to looking forward to. So.
Huh.
And actually, Tejalet made me think of another study that I've heard going on here at Penn is financial incentives to get teens to stop texting while driving. So using those tools you mentioned, but for a different purpose.
Yeah.
Right.
Ben, I wanted to ask you if if your audience at the New England Journal of Medicine was a clinician audience, what do you think the most important message that they should take out of your paper?
Well, I think there are two, actually. I think there's an important clinical message that if you can get people to accept incentive programs where they have to put something in of their own at the beginning, can be very effective. That's sort of the clinical message, and I think this trial does represent an important step forward in the design and conduct of randomized studies in sort of an electronic age. So we didn't, this trial, all the data was collected and transmitted over an electronic platform. We never saw any of these people in a clinic.
Yeah.
And we used some really interesting methods for randomization and for the analysis of the data. I'm a little bit biased because I'm the statistician, so I found the design elements particularly interesting, but I think those are just as important.
Well, we're right about it at time. Unexpectedly, I didn't think that we would go this long. And Ben French and Tejal Naik, I want to thank you so much for your time today.
Thanks very much, Joe. And I just wanted to go back and point to something that I misspoke about earlier, and that was the expected payouts in each of the arms. Subjects in some arms could earn more than $800, and if you look at the figure S2 in the supplementary appendix of the paper, it explains those potential payouts.
Okay, I have to confess I did not look at the supplemental.
Well, and I hadn't looked at it in a little while either.
Okay, thank you again.
Thank you.
Thank you.